great state to practice in. This morning we'll focus on dermatomyositis. I know that there have been several sessions already discussing dermatomyositis. We'll just dig a little bit deeper about dermatomyositis, and then hopefully at the end of the session you'll have any questions for me that I can address. A few disclosures. I've received clinical trial support. I also am going to talk about several treatments that will be off-label. So many of our diseases are rare, and we have not a lot of studies that tell us that they're effective. And so because of that, the FDA does not have an approved indication for the medicines that are used. All right, so let's go actually to our learning objectives. So there are 4 main learning objectives. The first one is to discuss dermatomyositis. What is it? What's the definition, and how do we diagnose it? We'll also appreciate how people are affected differently. So there's different ways that dermatomyositis affects every individual. So we'll go through a few of patient cases, patients that I have seen. We'll talk about the various treatment options, and then we'll discuss a bit about short and long-term prognosis. Oops, wrong way. All right, hold on. Okay, so dermatomyositis, what is it? We know it to be an autoimmune disease that affects both the skin and the muscles. Is it on?
Yes, it's running.
Okay.
Thank you.
So let's take a step back. What is an autoimmune disease? An autoimmune disease is a disease where your immune system goes awry, and it sometimes is an abstract concept to understand. When the immune system goes awry, it's not recognizing your own body tissues and cells. So our immune system functions to protect you from invading viruses, bacteria, and other organisms. And it's a very complex way that it does that. It mounts an inflammatory, immune-mediated response. So usually it works very well to protect you, or you wouldn't be alive today. But sometimes the immune system gets tricked or confused, and then recognizes your tissues as being foreign and starts to make inflammation against the tissues. And so that's an autoimmune disease. And there are 2 main types of cells in the immune system, the T cells and the B cells. The T cells and the B cells function together or interact closely to protect your body from invading organisms. They talk to each other, but sometimes those T cells and B cells are too hyperactive, so they're doing more than what they should be doing because they're activated, and then produce an inflammatory response. So how it may all start, we think of it as an interplay between the environment and your genes. So you inherit genes from your parents, and these genes may make you more susceptible for getting certain autoimmune diseases. But then you could be exposed to a trigger, and we don't know all the triggers. We know there may be some. For example, the ultraviolet radiation, ultraviolet light. If some people are in ultraviolet light for a long period of time, it may then trigger this abnormal response, so this abnormal immune response, which is determined by the genes that you have. So then the immune system loses the tolerance or thinks your tissues are foreign and starts to make the inflammation. When you get inflammation, it may be in multiple areas of your body. When the inflammation is sustained, meaning it doesn't go away, that's where you get the damage. And then when you get the damage, then that means it's irreversible, unfortunately. So we try to get you before, we try to get that inflammation before you get into damage. But clinically, how does that manifest? So people get rashes, which we'll go into several pictures. They get very weak. They have trouble even doing the things they usually can do, such as normal things, getting up and getting ready in the morning, getting dressed, fixing breakfast, those kinds of things. Joints may become very swollen, especially the hands and the wrist, and very stiff. Okay, so there are three main types of dermatomyositis. There's the amyopathic dermatomyositis. Those are the patients that have the rashes without muscle involvement, so they have no muscle weakness. Usually we wait 6 months or longer before saying you have amyopathic dermatomyositis. And why do we do that? It's because we're waiting to see if you're gonna get weak. Sometimes our autoimmune diseases evolve slowly and might take time, time being a couple weeks to a couple of months. So that's amyopathic. Hypomyopathic is a little bit harder to diagnose. Those are people who have the rashes. They might have some indication that there's some muscle involvement, such as they might have an elevated creatine kinase, which is a muscle enzyme, but they're clinically not weak. So they're not affected by loss of strength in any way. So we call that hypomyopathic or hypomyopathic dermatomyositis. And then the third, of course, the dermatomyositis. I'll focus more on the first one and the third one, and not so much the second one in this talk. Then there's a class here, the juvenile dermatomyositis patients. Those are children who have dermatomyositis. And typically they have to be age 16 or less to get that as a diagnosis. They may present a little differently than patients in the who are adults. For example, they may get more of the calcinosis or the calcium under the skin than the adult dermatomyositis patient. And we usually work them up a little differently. They're not as likely, for example, to get a muscle biopsy for diagnosis because it's invasive versus the patient who's the adult with dermatomyositis. So how common is it? We know it to be not very common. There's many studies out there, we call them epidemiology studies, that have shown that if you look at a population and we say roughly there's the incidence of 9.63 per million, that's a small number. There was a study that came out by one of my colleagues, Dr. Wetter. He's a dermatologist at Mayo Clinic. He did a population-based study of patients who have dermatomyositis, and these were the numbers he came up with. The peak age for adults is 45 to 65 years of age. For children, it's 5 to 15 years of age. And we know with many of our autoimmune diseases that females are more affected than males, such as in rheumatoid arthritis as well as lupus. The same goes for dermatomyositis. We also know that in the US, the African Americans tend to have dermatomyositis more commonly, and they may have a more severe course compared to the white population. All right, now this doesn't work. Oh, what do you think? That's right. All right, so here are some of the skin manifestations of dermatomyositis. So a very classic rash is something called the heliotrope rash. It's also known as a violaceous or purple rash. There is a flower called that's purple that's often referred to as a heliotrope flower. This is the heliotrope rash. On the upper eyelids, it's usually where it's seen, as well as in the corner of the eyelid there. Can also be below the eye. Not many things cause a heliotrope rash. When you see it, you know it's more than likely dermatomyositis. There's also Gottron's papules, so those are raised bumps on the hands usually, but it also can be on the elbows. Tends to occur over the surface of the joints where the knuckles are, where you see the Gottrins. And the Gottrins, when you see it, there are not many things that cause Gottrins papules. So we say that it's pathognomonic, meaning classic for dermatomyositis. More rashes, so what you see is the V sign and the shawl rash. So these are in areas that are in a photo-distributed area, or this is where you can get the photosensitive rashes. So the V sign and the shawl sign. Not pictured here is something called the holster sign. So it's the same kind of rash, but it's over the hips on both sides usually. And then it can also be rash here over the elbows, rash over the knees too. The nail folds could be affected, and we see the cuticles can have an overgrowth, and even with the naked eye, without using a microscope, you can see where there's hemorrhages there. We call them microhemorrhages or periungual hemorrhages. And that's not only seen in dermatomyositis. We can see it in other autoimmune diseases such as lupus and scleroderma. It can be reflective of skin activity from the dermatomyositis. And here is a blow-up representation of what we look for on the nails. So the box on the top left is the normal one, and then the top right, it's starting to become abnormal, and then more and more distorted. So on the top right, what you look for are these loops here. They're capillary loops. The capillaries get very thick and bristly at the ends. Sometimes there are more prominent capillaries and other ones stop to be prominent, so we call them dropout. They start to get sort of a wire brush in appearance, and then ultimately distortion can occur. You can also see some cuticle hypertrophy or cuticle overgrowth is what can be seen with the dermatomyositis. Many of my patients say that the cuticles can be painful and they bleed easily, and so sometimes I'll say avoid the manicures because they might cut the cuticle and cause them to bleed, and then the infection can easily set in, so you want to avoid that. The other thing too that I didn't mention about the rashes is that they're, as many of you probably know, intensely itchy rashes and can get very frustrating to the patient about how itchy they are. So the scalp rashes in particular are very itchy. The rashes at the back of the head here where the neck is can get very itchy as well. So these rashes, when they're itchy and you scratch a lot, it gets painful too. You get the what we call excoriations from all the scratching. What about calcinosis? I've seen many patients who have calcinosis, and it's frustrating to treat because then doesn't usually respond to treatment. So calcinosis can occur in a variety of different autoimmune diseases, not only dermatomyositis. For example, scleroderma has a lot of calcinosis that can occur. It can occur in many different forms. It can be a very, very tiny lump right in the fingernail, near the fingernail, and it's painful if you press too hard, or it can be a very large lump right under the surface of the skin, or it can be even below the skin where the tissue is, we call the subcutaneous fat, or it can even be deeper into the muscle, and there can be planes of calcium deposits there affecting how you move and how you sit down. So there's a spectrum of severity ranging from mild to severe. So what you see here is what we call a coronal image. So that's a front image of the thighs, and those are the muscles there. This is an MRI with T2. So T2 enhancement means you've used contrast. When you see use the contrast, you can see the calcium illuminated there. Here's an X-ray of the calcium deposits along the leg there, and that's in the muscle tissue and also in the subcutaneous part. So calcinosis is also a skin manifestation of dermatomyositis. What about the muscle weakness? Again, the spectrum is very wide, ranging from no muscle weakness, which is seen in amyopathic, to severe muscle weakness, with patients having a lot of difficulty with getting out of bed, holding their head up, or even swallowing, raising their arms over their head. So what we say, when we say weakness, we usually mean the proximal muscles. So proximal means your head is the center of your body, so the muscles that are closer to the center where your head is proximal. The distal muscles are like the wrist muscles and the finger muscles. So lots of times dermatomyositis really affects the proximal muscles. So it's the deltoid muscle, the biceps, the triceps muscle, and then the hip muscles, the muscles that are responsible for moving the hip out, moving the hip in, the butt muscles too, the gluteal muscles, and then the thigh muscles. So this can manifest with a lot of difficulty getting out of the car, getting out of the truck, walking up the stairs, getting out of bed, even getting off the toilet if the toilet's too low to the floor there. You need handlebars. Many patients have difficulty trying to sit on the floor. They may want to, maybe they want to play with their grandkids, but they have a hard time doing that, so they'll avoid sitting on the floor simply because they really can't get up on their own, or they need a lot of help from someone to get up. And then the difficulty with the swallowing can start with the really chunky foods like steak. Actually, people tend to avoid those kinds of foods, and they might lose weight as a result because they're changing their diet. The muscles that are affected are the upper neck muscles, not the lower esophageal muscles. And so it's just that initiation of the swallowing that could be very difficult to do. And then if it's significant enough, it could lead to even aspiration of the food, which you want to avoid that because of the inflammation that can happen in the lungs. Here's an MRI example of the inflammation that's seen in the muscle tissue. So the areas that are the white are the cells that are the inflammatory cells. And this is the right thigh and the left thigh. These are the quad muscles and then the hamstring muscles. You can also see that the distribution is patchy, meaning that it's not the entire muscle that's affected, but parts of the muscle. And sometimes people get a muscle biopsy and we don't see that inflammation, maybe because we missed it, because we know it to be patchy. And so we use sometimes the MRI to tell us where to go when we do the muscle biopsy, because we target then that patchy inflammation. Here's another example. This is a more severe example of inflammation in the muscle tissue, which you can see the white there. Okay, so how do we diagnose it? We do it by the exam. We look to see how strong you are. I try to overcome your muscle strength in your arms and in your legs and in your neck muscles. We measure 5 enzymes. These are the enzymes that are listed. The more common and specific enzyme is that creatine kinase. That's the one specific for the muscles. The other enzymes, as you probably know, can also be seen in the liver. So sometimes the liver enzymes are high. People are told, oh, you have high liver enzymes, you might have liver problems. No, it's because you have a muscle disease. And so those enzymes are coming from your muscles. So we'll often check that. There's a test called an EMG, and some of you might be familiar with it and some of you not, and not everyone gets it. It is a test that neurologists order and rheumatologists order, where we're trying to see how affected your muscles are. So they'll insert needles in different muscle groups, and they're looking for irritability of the muscle when you try to contract the muscle. and it tells us where to go if we want to do a muscle biopsy, so which muscle is the most affected on the EMG. The MRI we talked about, we'll sometimes use, and then ultimately the gold standard for diagnosing dermatomyositis would be a muscle biopsy. These are some of the EMG findings. These are words, they're what we call buzzwords, meaning words that we remember are abnormal in patients who have dermatomyositis. You don't need to remember them, just to know that that's what we look for when we do an EMG. Okay, what does the muscle biopsy look like? So what you're looking at is a very magnified view of muscle cells. So here is a muscle cell, here is one, here is one. They're also called muscle fibers. And what we look for when we do the biopsy is we're looking for these cells. These inflammatory cells is what we call them. And there are many different kinds of muscle diseases, inflammatory muscle diseases, and so there's different patterns that we're looking for. In dermatomyositis, that inflammation is usually around the vessels that are inside the muscle tissue, so we call that perivascular, and then around a muscle fascicle. So a muscle fascicle is a collection of muscle cells or muscle fibers, and that tends to be the distribution that we'll see. There's other ways that we do check that are immunocytochemical studies that I didn't put on the slide that will often help us too with diagnosing dermatomyositis. Necrotic and regenerating fibers means that the muscle tissue has broken down and then they're starting to try to get back to normal or regenerate or rebuild itself. And that is not specific for dermatomyositis, but is seen in a multitude of other myositis disorders as well as myopathies. Myopathies are muscle diseases without the inflammation. So this is an old criteria set. You might have seen it if you were on Myositis 101 talk yesterday. Old criteria. We say it's classification, not diagnostic criteria, but we still use it when we're seeing a patient and we're trying to determine if they're fitting within a dermatomyositis diagnosis. So there's 5 that you'll see in that criteria. If you got all 5, you definitely do have dermatomyositis. Some people don't though. Some people might only have that rash, which is just number 5, and we'll do a biopsy of the rash. And that might be all they have, and so it could be the amyopathic dermatomyositis. Some people might only have enzymes that are elevated and muscle weakness, but they might not have a muscle biopsy that shows definitely dermatomyositis. So that gets to be a little bit tricky then in figuring out if it's really dermatomyositis. Now, there are many antibodies and autoantibodies, and to understand what an antibody is, you have to know what the immune system does. The immune system, like I said at the beginning of the talk, is important for protecting you against infections. And one way that it does it is with an antibody. An antibody is like a little memory. It's a cell that is you can think of it as telling your body to remember this protein so that you can fight it again if it shows up again. So that's an antibody. But in our autoimmune diseases, we know a lot of people make antibodies, and when they have a certain antibody, we know that they might have a certain disease or a type of disease. So in dermatomyositis, there's 2 main types of antibodies. There's the myositis specific antibody, that's also known as MSA. And then the second one is the myositis associated antibody, that's also known as MAA. Now, the myositis specific means it's specific for a myositis or a dermatomyositis. The myositis associated can be seen in other autoimmune diseases, such as lupus or scleroderma, for example. And we know from the Myositis 101 talk that scleroderma and myositis can occur together. That's called an overlap myositis. They might have a myositis-associated antibody. Here is a table of the two. The left column are a few of the myositis-specific antibodies, and the column on the right is the myositis-associated antibody. So I'll focus a bit more on the left because it's more to do with the dermatomyositis. You might have already heard about the anti-synthetase antibodies. So more commonly, that's the Jo-1 antibody, and it was described early 1990s, 1990, I think. And the Jo-1 is seen in people who have the anti-synthetase syndrome. So those are the patients who have the interstitial lung disease or inflammation in their lungs with myositis. There's a total of 8. The Jo-1 is the more common one. The Mi2 was first described in 1985 by Dr. Targop. These are patients who have the classic rashes of dermatomyositis, and they might respond very well to treatment, such as with steroids. Signal recognition particle is seen in necrotizing myopathies, and not so much dermatomyositis, but is also classified as a myositis-specific antibody. The TIP1 gamma is used to be known as the P155, 140 kilodalton, I believe, protein. So this antibody is also seen with rashes and in some people cancer. So we know that there can be an association of cancer with that particular antibody. The NXP2 is also an antibody seen in dermatomyositis and associated sometimes with cancer, maybe not as strongly as the TIP1 gamma. The MDA5 I'll talk about a little bit later, and that's seen with amyopathic dermatomyositis commonly, and in a very small group of people who get the interstitial lung disease. And in that group of people, they may get very severe lung disease, even leading to very negative outcomes over a short period of time. The other ones are, the SIE is not as clearly defined, but we know it to be found in myositis patients. The MHC-CoA reductase antibody is seen in necrotizing myopathies, and the anti-CN1A is with the IBM patients. On the right are a few of the myositis-associated antibodies. The top one can be seen with scleroderma myositis overlap. Those patients may also have calcinosis, as well as the NXP2 antibody. You can see calcinosis in the juvenile dermatomyositis. So now we'll move on to appreciating how dermatomyositis affects people differently. We'll start with this first patient. This was a 32-year-old gentleman, Hispanic background, and he actually presented with a lot of arthritis, a lot of swelling in the hands, and his doctors thought he had rheumatoid arthritis because there was so much swelling and stiffness in his hands. Couldn't use the hands very well, couldn't make a fist at all. And then the rash. So the rash, the face was very red, almost lobster red, very pronounced rash on the face. Not a lot of weakness, in fact, on his exam, no weakness at all. He had normal muscle enzymes, but he had the positive MDA5 antibody, which was interesting. That's the myositis-specific antibody. So these were his hands. So what you're seeing here is something called inverse Gottron's papules. So I said in a couple slides before, Gottron's occurs over the hands. These are Gottron's that occur in the palms and in the fingers, the digital pads. They can be painful too. Seems to be described in people who have that MDA5 antibody, and so that's what he had. So that was one of the first clues that he could have the dermatomyositis, the MDA5 variant dermatomyositis. So these patients are a bit different from other dermatomyositis patients. They can have a lot of arthritis. They can have severe rashes, even rashes occurring on the palms of their hands instead of on the outer aspect of the hands or the back of the hands. Sometimes they can get more sores inside the mouth too, which is a little different from other patients. So it's actually first described in a group of patients of South Korean and Japanese descent. And we called them clinically amyopathic dermatomyositis. We know the antibody targets a protein called the Melanoma Differentiation Association gene 5 protein. This is a protein that's found in the cytoplasm of the cell. So the cell has a nucleus and a cytoplasm. It's in the cytoplasm. There's a lot of speculation as to what this protein does. We know it's part of the immune system function. And it may help to detect whether there's a virus that's invaded the body. And then when it does that, it triggers something called type 1 interferon. So that's actually what your body can make as a response to make more inflammation. So we call that type 1 interferon, or the words type 1 interferon signature has been seen in people who have the dermatomyositis. And then what was interesting as well is that these patients developed interstitial lung disease that was very rapid, very progressive, unfortunately. Now we'll move on to a second patient. So this was a gentleman, and he had fevers for a long time, and no one could figure the fevers out. He had a lot of workup for excluding infection. Nobody found any infection, but he kept having fevers. And then he started developing weakness, and he started having trouble with the swallowing. His workup showed high enzymes. His EMG was abnormal. So ultimately it led to a muscle biopsy. And I remember this was a patient who didn't have a lot of rashes, so we weren't really sure what kind of muscle disease was going on. The muscle biopsy showed dermatomyositis. So I called the patient up and said, well, you have dermatomyositis. We need to make sure there's no cancer. So that's what we did. There's different ways of figuring it out. You could do CAT scans or CT scans. You can do a PET CT scan. In his situation, as he'd gone through so many scans and didn't find anything, we decided to do a PET scan. And we did, and it was abnormal. And that led to an EGD. EGD is a procedure where they look down the throat and the esophagus and at the stomach. So this was the PET scan, and usually the brain's supposed to light up because your brain is active, right? It should be. Mine should be too. So the brain is white, the bladder is too, the kidneys because it processes it. But then you see here, what's that? That's not normal. So this is right in the esophagus, right there. It's a large tumor in the esophagus. So that's what kind of prompted us, well, we need to get that EGD and see what that is, and this is what it was. It was a tumor. So it ended up being esophageal cancer. But this patient illustrates that dermatomyositis can be associated with cancer. Not in everyone, but we know it is a true association. And it's something that we've known for quite a long time, since the turn of the 20th century. So first described in a patient who had stomach cancer or gastric cancer, and then they had the manifestations of the rash of dermatomyositis. So I'd say approximately, it's not a hard and fast number, but approximately 25% of newly diagnosed dermatomyositis patients that are older in age, such as older than age 50, and may have a cancer. That cancer risk is highest at the time of diagnosis. So it's usually seen in the first year. Can be up to 3 years, but I typically see if there is a cancer, it's at the time of diagnosis or within that first year. Also, the patients look sick. They've been losing weight. They've been having fevers. They may even have something called night sweats, where they're drenching their sheets at night. It's waking them up, and they have to change their clothes, their night clothes, and their sheets because they're so sweaty. The cancers that tend to be represented are the more common cancers, such as we know lung cancer to be common. So lung cancer is a cancer that can be seen. In women, we know it's breast is cancer, and ovarian cancer seems to be disproportionately represented as well in dermatomyositis, meaning it can be a common cancer even though ovarian is not as common overall. Colon cancer, I've seen bladder cancer, and of course esophageal. I've also seen lymphomas with dermatomyositis. Now moving on to patient 3. So this is a different patient now, woman in her 50s, later 50s, and she had started getting rashes. The rashes were worse in the sun. She was out in the sun for a while. Came in and a very itchy rash over the head and patches of red rash on the forehead and the face. Got a little bit of arthritis. Well, a skin biopsy, there's something called vacuolar interface dermatitis. Those are words to describe inflammation of the skin cells. Not specific though for dermatomyositis, because we can also see that with lupus. Chest x-ray showed what we call bibasilar, which means at the bottom of the lungs on both sides. Infiltrates, which is inflammation. Well, when she was doing all her tests, she kept getting more and more short of breath. She couldn't walk very well, or very far, I should say, because of the shortness of breath. She ended up being admitted to the ICU and immediately intubated and on a ventilator because her lungs are failing on her very quickly. And unfortunately, she died after 2 weeks, and despite the treatment. So this is another example of how dermatomyositis affected her, but she had significant lung involvement. And these were the lungs, and what you're seeing, that white there is the inflammation that we call infiltrates in the lungs, and it can progress and get worse, and those were hers. So what about the lung manifestations? We often think about interstitial lung disease because it can happen in a third of our patients with dermatomyositis. People just might have a dry cough, and then the cough gets worse and worse, and then they'll get short of breath. And it might be with a lot of activity at first and then just a little bit of activity, so it could get worse that way. Sometimes the muscles that control your breathing, which we call the intercostal or thoracic muscles, can get inflamed. Because of that, it's hard to take a deep breath in. So when you try to inspire, it's limited, so you could have respiratory muscle weakness. And then we know the Jo-1 antibody can be positive in these patients with the lung disease. Sometimes there's a little bit of rash and a whole lot of lung disease. Sometimes there's a little bit of muscle and a whole lot of lung disease. So there may be disproportionate. Sometimes there's very little muscle and a lot of lung, or a little bit of lung and a lot of muscle. A lot of variation there. There's also something called pulmonary hypertension. That happens to the heart. It can happen where if you have a lot of lung problems, your lungs automatically react to low oxygen levels by narrowing the vessels in the lungs. They constrict. So as a defense mechanism, they'll go like this, they'll constrict. And when that happens, that increases the pressure in your lungs that goes back to your heart, and you get that pulmonary hypertension. And if that happens, then you can get short of breath, not only because of the lung disease, but also because of the pulmonary hypertension. Because your heart is trying to beat harder to push out the blood into the rest of your body. It has to work against that as a barrier. All right, so more about it. The onset of the lung disease may be variable, meaning it could just be happening at the time of the diagnosis, or maybe a little bit later. Usually don't see it if you are in remission. You don't usually see the lung disease manifesting. The many different kinds of courses can be very severe, or it can be something called asymptomatic, where you get a CT and you see the lung fibrosis or infiltrates, but you're not affected by it, meaning you're not having a lot of trouble with breathing or coughing. Your pulmonary function testing can show something called restrictive physiology, meaning that your forced vital capacity is less than 80%. There's also different types of interstitial lung disease. The more common one is called NSIP, nonspecific interstitial pneumonia. The other types include cryptogenic organizing, that's COP, and then UIP, which is usual interstitial pneumonia. The usual interstitial pneumonia is the one that is more severe in that it doesn't always respond to treatment, and we think of it as refractory. Different kinds of things seen on chest imaging. These words are all kind of medical terminology you don't have to remember, just showing that there's inflammation and abnormal enlargement of the lung tubes with loss of lung volume. And in about a third of patients, it leads to poor functional status. So another chest x-ray, again showing the infiltrates on both sides. And then going to patient number 4, this is someone with juvenile dermatomyositis. So this was a young girl. She was diagnosed when she was 7, and she had the rashes, the same as an adult, really red over the heliotrope rash, for example. But she also had calcinosis that was quite severe. And so the calcinosis in her was actually all in her muscles. Thigh muscles and the buttock muscles had sheets of calcium deposits. It was very painful to her. I think she was in gymnastics or cheerleading. It was hard for her to get through her exercises because it was restricting her mobility. And if she was trying to sit down, it hurt because it would push on nerve bundles. She'd been on a variety of treatments, as you see here. And as I mentioned before, calcinosis is very hard to treat. And as you can see, she didn't really respond. So she had gone through a lot of surgeries. Debulking means to remove a large chunk of something, and she had lots of surgeries to remove the chunks of calcium. This was what was seen on her MRI there and on the CT on the right there. So the white represents the calcium deposits. And this was her surgery. So lots of surgeries, and it just shows the extent of the calcium right under the skin. So these are calcium deposits there in the muscle, even liquefied calcium. So she had even the calcium spurting out during the surgery because she had so much of it, such a high calcium burden. So she too had dermatomyositis, but a lot more calcinosis than others. So what about calcinosis? More into that a little later. So this was how she was treated. She'd had numerous hospitalizations, numerous aspirations. They would get infected, so she had to be put on antibiotics a lot. Eventually she went off her medications, did fine, but then the calcinosis came back in kind of the same area, but a smaller area, and now back on medication. Okay, so calcinosis means there's deposition of calcium deposits. We call it hydroxyapatite calcium phosphate. We don't really understand why it happens. It might be because the cell membranes are become injured by sustained inflammation, and so the calcium inside the cell leaks out into the tissues. Maybe that's what's happening. This is speculation. We know that in adults, it's about 15 to 20%, in children 30%, sometimes even higher than that. And then the many patterns, as I talked about, small lumps ranging to larger lumps to sheets of calcification. What about non-white groups? So we know that there are differences among groups, the white, Hispanic, African American groups of patients. Patients who have darker skin, they may get the rash, but their doctors may not be able to see the rash very well because of the darker skin. There may be a higher rate of calcinosis too, and especially in the non-white children who have JDM. We know that the muscle enzymes are higher in the African American population, just normally, that's what happens. But we also know in dermatomyositis they're higher too. They might have more severe organ involvement, such as lung and cardiac involvement, higher rates of hospitalization, and even higher mortality, unfortunately. So now move into the third learning objective, and we'll talk about the varied treatment options. First, before I start really going into too much detail, everyone is different, right? We're all different. So what works for one person may not work for the next person sitting next to you. So I see a lot of dermatomyositis patients. All my patients teach me something different. So we just try to figure it out. It's a journey. We go on together to figure it out. What's going to work, what's not going to work. I also think there should be many specialists involved because dermatomyositis affects many organs. Sometimes it's only the skin, but often it's more than just the skin. But if the skin's involved and it's heavily involved, a dermatologist is helpful. Neurologist for the muscles, rheumatologist for muscle and joints. Physical medicine doctor is important for working with you, with giving you an individualized physical therapy program, working with the therapist. The pulmonologists are very important for your lung disease, if that's what you have. Cardiologists are very important for your heart disease. And then as in the last patient we talked about, the surgeons may be important in doing muscle biopsies or removing the calcinosis. So you see it's varied, and as I said in the beginning of the talk, we don't have a whole lot of large clinical trials to tell us for sure what's going to work. Here's my approach to treatment, and it's not everyone's approach to treatment, so I always preface it to say my approach. I use a lot of glucocorticoids. That's the first line. We know they work quickly with reducing inflammation. They work where when you give it, you notice an effect if it's a high enough dose right away within a few days. Many different ways of getting glucocorticoids: topical for the skin, oral, or IV. It depends how severe you are with how much of the glucocorticoids you're going to get. So if you're very severe, these are patients who are in the hospital, for example, they can't swallow, they get the IV steroids, and they might get the couple of sessions of those steroids every day for a couple of days in a row. If you're medium severe, you might get a medium dose of steroids, and if you're just a little bit, you might get a little bit of steroids or not at all. So a lot of difference. The first two, azathioprine or methotrexate, I use initially as a steroid-sparing agent. What does that mean? It means that we know steroids work, but we know they cause side effects. So we try as much as possible to limit your exposure to medium to high doses of steroids for prolonged periods of time. What helps us do that? These medicines help us do it. The azathioprine, methotrexate, or mycophenolate mofetil. All of them are likely very comparable. It depends on who you are and deciding which one to choose first. If you have lung involvement, maybe your doctors might be more likely to choose the mycophenolate mofetil over the methotrexate. Once you're on the steroids, you're usually on it for some period of time, at least in the beginning, when you're first diagnosed, and then you try to go down or taper, we call that taper, over a couple of weeks to a couple of months, sometimes longer. Sometimes people are never off steroids too. Sometimes we go as low as we can, and it might be very low dose, like I have people on 2 milligrams or 3 milligrams, but they can't get any lower because their body needs it or they flare without the steroids. What other things? So antimalarials, that's for example hydroxychloroquine, is helpful for skin. not for muscle. Sometimes it's not the only one that's going to help the skin though. So we might use it, it might not be enough for people who have the severe amyopathic dermatomyositis. You might have heard of IVIG or intravenous immunoglobulin. I do use it a lot. I've used it initially when people are diagnosed, and I'll use it until something else is going to kick in, which we call the maintenance immunosuppressive agent. So we call that a bridge therapy. It also works right away. I should say the other medicines like methotrexate and azathioprine do not. They take several weeks to several months to really get working, and because of that, sometimes you need something more like the IVIG to help things along so things can settle down quicker. The IVIG is not always tolerated. Sometimes headaches happen, and headaches can be severe where they have to go to the emergency room, unfortunately. If that's the case, we have to stop the IVIG. It might be because they're getting too much of the IVIG or they're not getting enough fluids in with the IVIG. Some patients even get the aseptic meningitis from IVIG. Uncommonly, you can see blood clots related to IVIG use. So there are side effects, but for the most part, tolerated. What about the patient who has the severe dermatomyositis with lung disease? What do? Cyclophosphamide I've used, usually IV over oral. The oral cyclophosphamide can irritate the bladder lining more and cause bleeding in the bladder, so I tend to use the IV more. We do know there is some data that tells us in small series of patients that it helps with the lung disease. Then there are the calcineurin inhibitors such as tacrolimus. I've used tacrolimus too for patients who have interstitial lung disease. These are very potent medicines with serious side effects, including infection risks. Can also lower your white count very low, so that could be a problem. It can cause kidney problems, rashes, high blood pressure, so you got to be monitored very closely when you're on these medicines. What about rituximab? You might have heard of the rituximab. It's what we call a B-cell depleting agent. More and more it's been used to treat dermatomyositis. There was a large trial published 2013. It involved juvenile and adult dermatomyositis patients. They didn't meet their primary endpoint, I think probably methodology reasons, but there was a substantial proportion of patients who did improve with the rituximab. So I will use that as well. Not first line, but if you're not responding, might add it to what you're on, or take away one thing and add this on. Patients who have the Jo-1 antibody or the Mi2, they've done studies that have shown that they might be a little more responsive to the rituximab than patients who don't. So there might be a little bit of a benefit to choosing that. And we know the titers can decrease, like the Jo-1, if we use the rituximab. Then what about calcinosis? So there's actually a very long list, and this is a shortened list of numerous therapies that have been tried for calcinosis. So some therapies you see there. The one that I've used that's been helpful is the topical sodium thiosulfate. It's a compounded agent in zinc oxide, and it helps for the very superficial calcinosis. That one I've seen benefit. Other ones, hit or miss, not always helpful. Okay, these are some emerging therapeutics on the horizon. I won't go into too much detail. Part of it is because of time, but we do know there are trials that are ongoing that have been using these agents. I've not used any of these except for the two top ones. The tocilizumab is used in the rheumatoid arthritis patients. Affects the IL-6 block receptor. And IL-6 is what we call a cytokine, which is high in inflammation, so it may block that. The Janus kinase inhibitors, more commonly used for RA, but might even now be helpful for people who have really severe skin disease. So now there's been small studies that are showing that, and case reports as well. Abatacept is used for RA. There was a small study said maybe it's helpful for polymyositis and dermatomyositis. The other ones not commonly used yet and just in trials, such as lanabecin, I think is how you pronounce it. Phase 3 trial underway, helpful for cutaneous involvement. And then the last one, it blocks the type 1 interferon signature. Physical therapy. Dr. Alexanderson talks a lot about that here at this conference. Very beneficial. So the old saying, if you don't use it, you lose it, is true. If you have a lot of muscle reserve, meaning you're already very conditioned at the time of your diagnosis, you may not be as severely affected as someone who is not. So if you're not in physical therapy, try to get into a physical therapy program. Helps with regenerating your muscle tissue. These are ways in how we assess how the treatment is working. A lot of times I use the strength test, so the physical exam, and then I measure the muscle enzymes. Global assessment means how you think you're doing. You tell me, you fill out the surveys, and then how I think you're doing too. So we put that all together, and we've done research using these kinds of ways of assessing treatment response. Like I said, I do your muscle strength testing, check your muscle enzymes. I might repeat an EMG if I don't think you're responding well and you might be progressing, or in a muscle MRI. If you have lung involvement, pulmonary function testing is important, just to make sure you're not getting worse or progressing. Sun is important to avoid if you've got a lot of rashes. Sometimes I'll tell people the sun is no longer your friend. That just means be careful. Wear the wide-brimmed hats. Use the sunblock, reapply every 2 hours. SPF of 50 or higher. Some people also wear photoprotective clothing because they're highly responsive to the UV radiation and they want to avoid that. Can be expensive, the clothing. Your rheumatologist or neurologist will do this. They'll screen for any underlying infections, emphasize vaccinations. Here are a few of the vaccines. Always screen for diabetes and high blood pressure, high cholesterol, and check you for osteoporosis. Other things to remember: if you're of childbearing age, certain treatments may not be appropriate for you, such as the mycophenolate mofetil or the CellCept. Pneumocystis prophylaxis is important if you're on moderate to high doses of steroids and you already have underlying lung disease. I've seen pneumocystis pneumonia. It's very serious, so you want to avoid that. And then many infections can happen when you're on immunosuppressants, unfortunately. So it's always a balance of treating the autoimmune disease but making sure you don't get the side effects. Many people get reflux, and sometimes it's hard to treat the reflux, but these are ways that I've told people to treat it. So proton pump inhibitors, don't eat too late at night, elevate the head of the bed. There's a thought expert opinion that if it's not controlled, then it might trigger some inflammation in the lungs because you could aspirate. Well, I'm told that I need to stop. We're getting towards the end or at the end. Okay, so can I just switch, maybe go to the last one and just talk about this really brief short-term prognosis. I just want to say it really depends on the severity of your disease and the number of organs that are being involved. Usually takes a year longer to get back to your baseline. Sometimes people don't. So there's sometimes some people who don't ever get back to where they were before they were diagnosed. Some factors could be how old you are when you were diagnosed with it, and whether you have lung disease, and if you've come down with really serious infections. Long-term prognosis has been getting better and better. So historically, the studies have shown that there was a reduced lifespan. Not so much anymore, I think, because we're recognizing this earlier and treating you more intensively. And we've got more varieties for treatments too. Many people are different, but a lot of times this is a chronic disease. Uncommonly, it's what we call monophasic, where you get it and it goes away and you get off the treatment. But more commonly, you need to remain on treatment because it comes back if you take away the treatment, meaning flare. We won't go so much into the studies, just to show that there has been improvement in prognosis along with the therapy. This was a study that showed that some of the factors for higher mortality you see there, such as males, heart involvement, and interstitial lung disease. People sometimes, when they're treated with immunosuppressants, can get infections, and if they're severe, it leads to poor outcomes, and sometimes that's a higher mortality too. All right, and what do they show overall? So the good news is at 5 years, 95% survival rate, 92% at 10 years. That's as long as these studies have been built to look at. So here is my summary slide. I hope that you have a better understanding about dermatomyositis. Know that it affects sometimes only the skin, which we call amyopathic, or the skin and the muscle. Know that many people are so different, so very varied presentations. Treatments should be multidisciplinary, involving multiple specialists. And then the short and long-term prognosis is better, but really depends on the severity of your disease and the number of organs involved. So with that, I will take any questions. So thank you for your time and attention. Yes, most definitely you will get the slides. Yes, most definitely. Slides will be posted. Yes, don't forget to fill out your evaluation.
I have DM, but I've been dealing with calcinosis, so I have had infections. But to me, I felt like the prednisone was causing the infections. So it's supposed to suppress the immune system, but I had to wind up. I was getting infected with staph, so they had to do muscle flap and do skin grafting. So have you ever removed or did surgery on a patient? I mean, had to have a patient get removal of the calcinosis because of the infection? And does it come back?
A good question. So the question is, has anyone had to have removal of an infected calcinosis, plaque, right? And does it come back? So yes, I have seen that where the calcinosis can, because the skin barrier is disrupted, on your skin are many bacteria, and then they go right into that area of disruption and set up house and cause infection. And just like you pointed out, when you're on prednisone, you have that higher risk of infection, and the prednisone thins the skin too, so makes that more likely infection can be caused by that. It can come back, unfortunately, when it is removed. Sometimes it doesn't, but sometimes it does.
Because you showed the 7-year-old that had calcifications during the surgery. I don't know what area that was, but I have had several that leaked out because of the staph infection on both legs, which caused my legs to rub together. But it has not come back. It's been over 5 years. But the healing process, because I was on prednisone, it took a long time for me to start back walking and moving around.
That's a good sign that it won't come back then, if it's been 5 years. Yeah, for sure.
Thank you.
You're welcome. More questions? I think I saw your hand.
Yeah, I've been diagnosed with DM, but I have no rash. Is that common or uncommon, or
It's
have I
uncommon.
been misdiagnosed?
It's uncommon if you have no rash. The rashes are subtle, so you might have had a little bit of a rash, and if you're put on treatment, it could have gone away. Sometimes I've seen it where it's just in the cuticles, and then it's a very fine red rash in the elbow, and it's still kind of a rash, but it could go away very quickly. So a way to figure it out more, you do a muscle biopsy, and there's special what we call immunocytochemical studies where they look at features of your muscle tissue, and they could tell if there's certain immune cells that are commonly seen in dermatomyositis that affects the muscle. And other ways is if you have a myositis-specific antibody.
Yeah, that's how it's
Okay.
diagnosed.
Okay.
ASD2 was elevated.
Okay, good question.
Can ILD be diagnosed easily with just a chest x-ray?
No, chest x-rays are not very accurate. It can be if it's moderate to severe, but if you're short of breath and you have a cough and a chest x-ray is normal but you still have those symptoms, I'll usually get a CT, high resolution CT, very thin slices. Then you can really see the detail of the lung tissue and pick up the ILD there. Yeah, but if you don't have a lot of symptoms and the chest x-ray is normal, it's likely you don't have then ILD.
Yeah, because I get some symptoms, but chest x-ray didn't show anything. That's why.
Sometimes a breathing test helps too, the pulmonary function test.
All right, thank you.
Question?
I had a PET scan and it says something about glass appearance on my lungs. Does that constitute ILD?
It
A
showed
PET scan showed like scattered glass.
So probably did the PET scan show ground glass appearance? So ground glass is a word that's radiologists will use to describe interstitial lung disease sometimes, or inflammation in the lungs.
But my function test
Was normal, okay. Sometimes you're asymptomatic. It's just there and it doesn't mean anything. It's clinically not significant.
We are getting into breakfast time, so those of you that want to eat, you might want to consider keeping this a little short.
Question?
I'm supposed to ask a dermatologist this question, but I really broke out really bad on my face, the dark, made it really dark. Is it possible, and am I safe to get like laser? Have you ever had any patients that had it this so severe? Because I feel like I'm the only person with DM with such, because I do research and I haven't seen anybody that looks like me with this rash. And I'm wondering, have you ever came across someone that looked this much damage? Can it be lasered off?
The laser question, the question is skin damage. Have I seen anyone who's had severe skin damage like you? I have. When sometimes people get really red rashes and sometimes the rashes get really dark. That's what I've seen. The laser question, ask the dermatologist, because I don't use that in my practice.
I just want to know if it's like safe to do it.
I would ask the dermatologist, because I don't know for sure about the laser treatment very well. I know some people have gotten laser treatment.
Have you ever had a patient that had it this dark and then it went away? Or am I stuck with this?
If there's damage, sometimes not everything goes away, but it can be lessen in intensity, so it's not as obvious then, but might still be present.
And real quick, have you ever seen anybody with DM where their hands are like stuck and they can't open them up? Because I feel like that's a category of the IBM, is that what it's called?
IBM. So when the hands are stuck and can't open them up.
Yeah, because I don't hear any that being mentioned on the DM where your hands are like.
Right. We don't think of the DM affecting the hand muscles, or the small hand muscles here. That's more IBM. Sometimes people get very stiff and arthritis in the hands, and that might limit the mobility of the hands. But there's ways to distinguish between the arthritis and the weakness, the myopathy, if it's affecting the hand muscles. Okay, you're welcome. Yes, question in the back.
Any emerging therapeutics for ILD? How does somebody find out about that? And then what do you think of the alleged correlation between ferritin and ILD?
So the first question, two questions then. One is any therapeutics for ILD?
Yeah.
Okay, so the, ILD is, if it's severe and progressive, might require very potent medications, like that one slide that said Cytoxin. Some people have used even rituximab. Some people have used tacrolimus for the ILD. Yeah, it sounds like you're familiar with those medicines. Okay. Yeah, anything emerging. Those are the common ones. There's newer medicines emerging, but I don't think they're targeted for the ILD yet for the dermatomyositis patients. Not specific for ILD. They're the antifibrotic agents that the lung doctors will use. But they actually, if you have an autoimmune disease, don't use those antifibrotic agents. Yeah, so we just don't have enough data to tell us. We actually have a conference with the lung doctors at Mayo every month to 2 months going over patients who have the ILD and what's out there. So never stop looking. There's always trials. So you go to like the clinicaltrials.gov page and see if there's any open trials that you'd be candidate for. Yeah. What was it, the second part? Ferritin and ILD. So, you know, I know there's studies they've looked into that as a correlation. I don't know exactly the data behind it. I know that ferritin is what we call an acute phase reactant. So when you're inflamed for whatever reason, like infection or autoimmune disease, that ferritin can go up as a marker that your body has inflammation. How is that correlated to ILD? I don't know, to tell you the truth, but I know that they're looking into that.
You want to make sure you get breakfast. So. Thank you.
Yeah.
How long are you going to be around?
Thank you, everyone.
Thank you. Thank you.